So it looks like we are live on our YouTube channel. I wanted to thank everyone for joining us today. This is our second installment of our Ask an Expert Myeloma panel webinar. Today we're going to be kind of dividing and tackling this in two different segments. We have our COVID-19 risk factors for myeloma, MGUS, and smoldering patients. We're also going to be talking about systemic disparities and the impacts of COVID-19 in the context of both health in general and cancer. So that's kind of on our outline for today. If you haven't seen our first video, we do have that posted on our YouTube channel, so you can access that after. And we will be recording this webinar as well, so you'll be able to access that at a later time point also. I wanted to start off by introducing our three physicians that I have here with us today. And I'm just going to try to mute a couple people so that there's no background. Perfect. So we have Dr. Irene Ghobrial, who's a professor of medicine at Harvard Medical School. She's the principal investigator of the PROMISE study, which is a Stand Up to Cancer Dream Team grant. And she's a multiple myeloma hematologist at the Dana-Farber Cancer Institute, where she specializes on working with patients with precursor conditions to plasma cell cancers. We also have Dr. Karen Winkfield, who is the Director of Hematologic Radiation Oncology at Wake Forest Baptist Health in Winston-Salem, North Carolina, with a focus on lymphoma, leukemia, and multiple myeloma. She also serves as the Associate Director for Community Outreach and Engagement for the Comprehensive Cancer Center and is Director of the Office of Cancer Health Equity, which enables her to focus on championing cancer health equity for all. We also have Dr. Craig Cole, who's an assistant professor in the Division of Hematology and Oncology at Michigan State University Breslin Cancer Center, with a primary focus on clinical and a research interest in multiple myeloma. He has a strong commitment to patient empowerment and works closely with local and national patient advocacy associations. So that's our panel for today. Thank you all for being here. Just a couple of quick notes before we get started. If you do have questions that come up throughout the course of this webinar, you can submit them using either the YouTube chat option on the side of your screen. Those will be public, so everyone will be able to see them. If you do have a private question that you don't want your name to be out there, you can also email us at our Precursor inbox, which I will put up here, which is Precursor at, which is Precursor at partners.org. Which apparently I don't have a banner for. I'm sorry about that. I will put it, well, our team will put it, oh, here we go. There we go, sorry, technical difficulties. Okay, if you have a question that you want to be private, you can email us at this, and we have a great team working behind the scenes to help us with all of this. So we're gonna kind of do this in a couple of different segments. We'll start with a portion on health disparities, talking about African Americans and multiple myeloma. We'll then move on to treatment and symptom questions related to COVID-19, and we'll end on research regarding multiple myeloma, precursor conditions, as well as COVID-19. Finally, if we have some time, we'll answer some of those submitted questions, so get those in when you can. All right, and with that, I think we will get started. So I'm gonna start off with a question to Dr. Irene Ghobrial, who was on our last webinar, and just kind of, if you could give us an idea of why individuals of African descent are at an increase of developing MGUS, smoldering multiple myeloma. Does this also mean that cancer is more aggressive in these patient populations, and should these individuals be screening for multiple myeloma?
So thanks, Annie, and again, thank you everyone who is joining us today. And I actually want to thank Karen and Craig so much for being part of this discussion, and hopefully everyone is safe at home, and we all someday look back at this and laugh. Having said that, I think the whole idea why we started the PROMISE study was to ask the question, why are African Americans or African descent individuals at a higher risk in multiple myeloma? We know from prior studies that they have a 3 times higher chance of developing myeloma compared to the Caucasian population. What we don't understand is why. Is there certain inherited factors that we have, or certain immune microenvironmental factors, or both of them leading to multiple factors leading to that increased risk. We know that when we look at the genomic data of patients of African descent, and again, Craig can correct me and can help with that, from the COMPASS MMRF data, they actually have better cytogenetics in general, or good cytogenetics, and if well treated, if receiving the right therapy, would have a potentially better prognosis. Yet, after knowing that, we know that most African Americans do not get the opportunity to be enrolled on clinical trials, do not get the opportunity to get the best care possible. And we want to close that gap. We want to be able, all of us, to say, here's an opportunity for us to offer the best care for individuals who potentially may have better genomic aberrations and may have a potentially longer survival, and yet they are at much higher risk. And it's always hard for me to think, and that's why we created this PROMISE study. For all other cancers, breast cancer, colon cancer, we screen because we know that cancer screening saves lives. We go to our primary care doctor, we look for colon cancer, we look for breast cancer early, and if I get early breast cancer, I want that removed early on. I don't want to wait until I have metastatic disease and then you treat me. Yet for myeloma, we don't go looking for it, although it's a simple blood test. And if I have an early MGUS, which is an early precursor to myeloma, I would love to be treated early before I develop end organ damage, before I develop fractures in my bones and kidney failure. And the hope of PROMISE study is that we screen 50,000 individuals. We detect in 20% of these individuals, if they're African American, and potentially even more, we detect if you have an early MGUS, and we potentially treat you early so that someday screening for myeloma becomes a standard of care. And someday we will not diagnose myeloma by CRAB criteria or end organ damage or symptoms. We will screen for it and find it early and treat you early before you develop any symptoms.
Dr. Cole, on that note, if a patient is African American and also has a family history of multiple myeloma, so they don't only have one risk factor, they have two, does that increase in a greater extent their risk of developing multiple myeloma? And on a broader sense, why do you think multiple myeloma is not discussed as often in the African American community, even though it is the primary blood cancer among an African American population?
Yeah, well, thanks for inviting me. It's great to be here. And again, safe wishes to everybody that's out there. Being African American does, or being of African descent, does increase the risk of myeloma. That we know that, just like Irene had mentioned, that it's twice, that the incidence is twice as high in African Americans than in Caucasians. And really that risk is related to, just like Irene had mentioned, MGUS. The chances of going from MGUS to myeloma is no different between the races. But what makes the incidence of myeloma so high in African Americans is because of MGUS, and therefore, because a small percentage of MGUS patients will turn to myeloma, therefore multiple myeloma. We also know that having a primary family member that has myeloma or MGUS also increases their risk of having MGUS and potentially having myeloma. So it's not as straightforward as other cancers. So, for breast cancer, there's a BRCA1 gene. For prostate cancer, there are genes that are directly related to the increase in risk of a disease. For myeloma, it's a bit more cryptic and a bit more difficult to tease apart than some of the other cancers. So there are genes that we think can increase the susceptibility of developing MGUS and myeloma. And part of what the PROMISE study is trying to do is to see what genes could possibly be involved in causing specifically African Americans, but really for everybody, causing people to have MGUS and the potential for MGUS to turn into myeloma. Because right now, when we have patients that have MGUS, Right now, our standard is to, we check their blood counts over and over and over and over and over. And it would be really nice someday to be able to say, okay, we found that you have this precursor lesion because a family member of yours has MGUS or myeloma. We've done the genomics and we know exactly what can happen in the next few years with you. Therefore, we're going to follow you closely, or we may not even need to follow you at all. And that's where we want to get to have more information, especially genomic information, to be able to tell what's going to happen with this disease in the future. I think it's a really good question regarding, why don't we talk about multiple myeloma more? And it's a bit more of a difficult disease to discuss. When someone has melanoma, when they have skin cancer, you can just point to and say, well, there's my melanoma right there. Or if you have, breast cancer or colon cancer, people know where those organs are and they understand, where the cancer is. For myeloma, it takes a bit to explain someone exactly what myeloma is. And, a disease like monoclonal gammopathy of uncertain significance is especially difficult to discuss. You really can't go to church and say, by the way, I have monoclonal gammopathy of uncertain significance, without having to sit down and really go through and explain a lot of, the biology of the immune system. And so, I'm hoping that with a lot of the things that have happened with COVID, I think that the scientific education of the African American community, as well as the community in general, has really gone up. Understanding science, understanding, the cell biology class, which really didn't seem to matter so much, years ago, actually, is coming in pretty handy. And understanding that the immune system can get cancer. And when the immune system gets cancer, one of those types of cancer is called multiple myeloma. But I think the difficulty in discussing it is due to that is a lot of science that you have to discuss with someone in order to explain what you have.
Thank you, Dr. Cole. And that really sets me up great for my next question, because I think it's really important to consider and think about the local community. But I think something that the COVID-19 pandemic has really brought to light is kind of the systemic inequalities that exist across our healthcare system as a larger whole. And to that point, I'd love for Dr. Winkfield to talk a little bit about why and how the COVID pandemic has happened in the pandemic to exacerbate these systemic issues, such as systemic racism, lack of access to healthcare, biases, food deserts, et cetera. I could go on and on. Are you optimistic that real change will occur to lessen this gap in the future? And what are some steps that we as communities can take to improve equality in healthcare?
Well, thank you, Annie, for the question. And thank you for so much for having me today. Of course, you give me the difficult question. I must say, I'm going to quote Einstein on this one. I'd rather be an optimist and a fool than a pessimist and right. That being said, there are a lot of issues. I mean, you're talking about the social determinants of health. And so there are a lot of holes in our health care system that are being exacerbated, right? Lack of screening, inability to access care, the fact that insurance has been traditionally tied to employment, right? And so many people have lost their jobs and now they find themselves in this precarious situation of being uninsured. But beyond that, it's really important to think about what health is, which is a very different concept. And the healthcare system only impacts about 20 to 25% of what health is. And everything else, those social determinants that you've talked about, the conditions in which people live, work, and play, those are the things that actually have a much greater impact on one's health. And so, while I am cautiously optimistic that there is now this spotlight that's being shown about some of the issues, the inequities in our healthcare system, I think it's really important to remember that this is a much broader conversation to be held. There's been studies that shown that income impacts health. right? Socioeconomic status, which is income, education, occupation, that is the greatest driver of health outcomes. And so we've already heard the discussions around, you know, some of the issues related to access to care, right? They are absolutely driven by one's income and one's education, the health literacy, but they're also driven by information, right? And so that health literacy is kind of part and parcel of the socioeconomic status. And I just want to talk a little bit. I know Dr. Cole, you know, was talking a little bit. You asked the question around this, why African Americans aren't talking about multiple myeloma more. And part of it is if you think about what the health priorities are, particularly in communities that are traditionally underserved, you know, healthcare in general is not one of the things that's kind of high on the scale of things that people want to discuss. And then it's going to be the conversations that have been had around, when you look at cancer, it's going to be the cancers that we've spent time educating communities about. And we spend time educating communities around cancers that we can do something about, that we can screen for. And up until the PROMISE study, we've really not had a way to screen, right? And so that's why this study is really important, because for multiple myeloma, we now have a way to screen people. So now we can start doing some of the education. You think about breast cancer screening. You know, back in 20 years ago, we knew that African Americans had a much lower screening rate. And in some communities, they still do. But there's really this push kind of about 10, 15 years ago to really do dramatic education around the importance of screening. Screening saves lives. And we now see that in many communities, particularly communities with high proportions of African Americans, in fact, their screening rates in some cases, I know in Boston when I was there, the screening rates for African Americans are actually higher than some of the white individuals, right? So I think education is a part of that. And so again, cautiously optimistic, but the healthcare system itself has to change, but it's really that the social context, it's the environment in which people find themselves that really needs to change. That's going to require a deeper dive. That's going to really get into wealth inequality and thinking about how we can structure the way that our country works so that individuals who are working and working hard can make working wages or livable wages. The fact that our current salaries are not sustainable for people and they're not livable. People have to work 2 and 3 jobs. That makes that issue of health and well-being much lower on the list of priorities for individuals.
Thank you so much, Dr. Winkfield. I asked you a loaded question, and I think you did a great job solving it in 5 minutes, but obviously this is something that we're all going to need to continue to talk about moving forward. And I think that's something that our team at the PROMISE study is really dedicated to, is trying to get this conversation out there, because half of it is education and spreading the word about what this disease is and who it really impacts. And speaking of which, something that is a difficult point, and that I think Dr. Cole brought up a little bit earlier, is the issue of having uninsured patients. And I'm wondering if Dr. Cole, Dr. Winkfield, if you could address a little bit, what advice do you give to individuals who are interested in potentially screening for cancer, or have recently been given a cancer diagnosis but are uninsured? How do you handle that from a physician's standpoint?
Well, in fact, this has happened to when I was in clinic just a couple of days ago. That someone who actually had gone in with shortness of breath and was screened for COVID, and then discovered on blood tests to have a low blood count, and subsequently we found that the patient has a disease related to myeloma, Waldenstrom's macroglobulinemia, and the person was had gone through a COVID screening, and one of the drive up screening places that we had, and he was uninsured. And the first thing that we did was we connected him to our social worker, who was then able to do a fantastic job in mobilizing a lot of resources, both through the state and through charitable foundations that are in the area, as well as foundations that are for blood and cancer, like the Leukemia and Lymphoma Society, to really start getting him the care that he needs for his workup, and subsequently in us being able to treat him soon. And so, having, a finding that person to the social worker to help. But also, one thing that I was impressed with is how he was really empowered and really empowered himself. He was calling around also, seeing, what about the job that he had, if he was still had, some insurance possibilities with the place that he had just left. And so he was empowered, and a social worker was working, kind of worked as a team, trying to get him the help that he needs. And so I think one thing is to, be empowered, learn a lot, call. If you're uninsured, talk to your social worker at the healthcare facility that you go to. If you have insurance, call your insurance company, and and be proactive and work, mobilize the team around you to get the help that you need.
So one of the things that's been a challenge for me here in North Carolina is when I moved from Boston, where we had uninsured rates that were probably in the single digits, 4% or so, to now being in North Carolina and in rural North Carolina, where some of my counties that I serve are 20 to 30% uninsured. This is a big issue, right? Rural populations are struggling with access to screening of the cancers that we can screen for easily. It's not so easy sometimes in rural communities, and definitely if you're uninsured. So it's a good question. And one of the things that my team has done, the Office of Cancer Health Equity, has really partnered with lots of community-based organizations to really figure out how we can streamline screening for underserved populations. That includes we have a free mammography program, for instance. But for me, it's really important not to just set up screening. There has to be a bridge to care. If you're going to screen someone, there has to be something to do beyond that. So if someone has a diagnosis, then how can they get hooked in and tied into diagnostic testing to any of the subsequent treatments? And so it can be a challenge for some cancers. Colorectal cancer, for example, in North Carolina, we do not have a colorectal cancer screening program for the state, unlike Virginia that does. So if someone screens, they can get assistance through some of those programs. But to Dr. Cole's point, we've really utilized our social workers. I have a population health navigation program that I run through my office that really has been incredible about understanding what resources there are to the communities that we serve, rural communities, African American, Hispanic communities, those that have traditionally been so underserved. And so that we can understand that if there's someone who's knocking on our door, who's interested in getting screened, or who does come up with a diagnosis, has a positive diagnosis for cancer, that we know what resources are available to them and that we can point them in the right direction so that they can take care of their health and well-being.
Thank you, Dr. Winkfield. And I wanted to really start this webinar with these types of questions because I think when we're going to transition now to precursor conditions and COVID-19, and I think those really need to be considered in the context of the health disparities that we just discussed. But now I know that this is the kind of the loaded question that everyone's been waiting for. Dr. Ghobrial, I'm going to ask a couple of questions about precursor conditions with regard to COVID-19 risk. But to start us off, can you just briefly explain again what the difference is between MGUS and smoldering multiple myeloma, and what are the options right now for a patient who has a diagnosis, how can they treat it or prevent it from becoming symptomatic? And something that actually comes up in conversations a lot with patients is, why are MGUS and smoldering considered symptomless if they do have the ability to progress into multiple myeloma?
These are great questions. So maybe we'll start with, what is multiple myeloma? Multiple myeloma is a cancer of certain types of blood cells, which are the plasma cells. These are the mature lymphocytes, which, as we said, are one of the immune cells that we have. So they secrete antibodies, and in COVID-19, we know that those cells that secrete antibodies and can potentially protect us from COVID-19 and from other infections, these are those soldiers that make a difference. So one of those soldiers, the plasma cell, decided to become mutated, which becomes cancer cell-like in a very early event. And just like any other cancer, it doesn't suddenly show up and make you feel tired or have bone pain or anything like that. Although when a patient is diagnosed and goes to their doctor, the most common reason why we look for it is you have bone pain, you fell and you had a fracture, you have anemia in your blood, you have some kidney problems, and your doctor starts looking for multiple myeloma. And we diagnose it by looking at your bone marrow. We take a bone marrow biopsy and we find those bad cancer cells. We call them the plasma cells. And we can also diagnose it in your blood, which is a very smart, easy way for us to find it. We find the protein, the antibodies that those plasma cells secrete in your blood, and we can detect those specific antibodies. This time, they're not against COVID-19. They're just bad antibodies that are being secreted by the bad cancer cells. Now, if we look at myeloma, almost every single case of myeloma must have had that precursor condition for years and years. So if you are diagnosed today with multiple myeloma, you may have had those cancer cells in your body for the last 10, 15, 20 years, and you didn't know about it, because those cells start early by one event, and we don't know why. Something happened and that cancer cell changed. And then it starts growing very slowly. And then it changes your own immune system. And then it grows again. And we don't know why some people will grow very fast and get the disease. And some, it will never progress in their lifetime and they will not get the symptoms of the disease. So the precursor conditions, which means just before myeloma, when you don't have the lesions in your bones, when you don't have anemia, when you don't have kidney failure or high calcium, we call those precursor to multiple myeloma. And we have two of them. They were described by Dr. Bob Kyle, and I trained with Bob Kyle at Mayo Clinic. He's 95 years old now, and he's wonderful. And he started looking at many people who were completely asymptomatic in Olmsted County in Minnesota. And he found a lot of people who are completely normal, but they have that protein in their blood. And that antibody in their blood that indicates that you have those cancer cells in your bone marrow. And he had this big discussion with Jan Waldenstrom, another physician, for many years, because Dr. Waldenstrom said, no, this is benign. It's never going to become malignant. These are people who are doing fine. They have a tiny protein. Forget about it. And Bob Kyle was so good in saying, let's call it of undetermined significance, monoclonal gammopathy of undetermined significance, big long name, which means we know that you have a monoclonal type of protein. Clone is a type of cells that all look like brothers and sisters of each other. So they're one type. They're all coming from the same sisters and brothers of the same cell, but we don't know the significance of it. Well, that was 50 years ago when we didn't know the significance. Now we know what it is. And it means that your chance of going to myeloma in general is 1% per year. So it's very, very low. But if the numbers increase and your cells increase more in your bone marrow, and they now become more than 10% of all of the cells in your bone marrow, now it's just like the fire is. It's smoldering into myeloma. It's going into myeloma. It's getting started. So now your chance of going into myeloma is 10% per year. Again, it's not a big problem every year, 10% chance, but it's much higher than 1%. What we hope to do is we diagnose you early. We find out if you have MGUS or smoldering myeloma. And in many cases, in 99% chance, we tell you, let's just do nothing. Let's watch you, see you every 6 months or every year. We get to talk about family and about getting older, all of us together, and do nothing. In a small percentage of you, we say, let's make sure you don't have myeloma, or your numbers are going up so fast, your risk factors are so high, we think you should consider early treatment to prevent myeloma. And this is what we're hoping to do. So why is it important to be diagnosed early? The hope is that you don't get diagnosed when you have those symptoms, when it's already at the end stages. Having said that, many people with MGUS and smoldering don't have completely normal things. It means you may have neuropathy, you may have some kidney changes, you may have other changes that are already changing. Your immune system is not normal, even at the MGUS stage. And we're going to talk about that in COVID-19 situation. You have a lot of things that are not normal. So compared to a completely healthy individual, you are still at risk. And that's why it's important to see your doctor and continue to see us every 6 months or every year indefinitely.
Thank you, Dr. Ghobrial. And you hit on a really important point that I think is causing a lot of concern for our MGUS and smoldering patients right now. There's a general understanding of the risk of COVID-19 for the public, and I feel that there's a general understanding for a heightened risk for our myeloma patients. And we often talk about myeloma on a spectrum from MGUS to smoldering to multiple myeloma. where do the MGUS and smoldering patients fall in concerns with COVID-19 risk? Are they higher than in the general healthy public, but lower than a myeloma patient? How is a MGUS patient able to look and determine their risk of COVID-19? Perhaps Dr. Ghobrial and Dr. Cole can touch on that a bit.
Yeah, and I think all of us don't have the answer. Craig, do you want to answer that, and we can chime in?
So I'm going to work backwards from myeloma back, down to smoldering to MGUS. The more plasma cells you have, the plasma cells help you fight infection. They produce antibodies that can help clear things like viruses, bacteria, etc. When you have a cancer of the plasma cells, myeloma, it drives down the normal plasma cells that would help you fight infection. So one thing that, the one problem that people with myeloma have is that they don't produce the antibodies, the healthy virus and bacteria destroying antibodies that a normal immune system would produce. So they have lower antibody levels because they have a cancer of the immune system. The other thing that happens that with myeloma patients that increases their risk is that they have lower CD4 T cells. And CD4 T cells also help us fight off viruses. And we know when patients are diagnosed with myeloma, they have lower CD4 T cells. And it can get lower when we actually treat the myeloma. So that's another hit to the immune system. And then when patients are diagnosed with myeloma, they're usually older, and we know that older patients and older people have lower immune systems and have a higher risk of COVID. We know that the more plasma cells you have, the closer you are to myeloma, the more the problems I just discussed occur. So someone with myeloma has an immune system that has more lesions acquired to it by having more malignant plasma cells. Someone with smoldering myeloma, less so, and someone with MGUS, even less than that, at least theoretically. When you add treatment onto myeloma, then that increases that risk. So I think that, being vigilant and understanding the risk can really go a long way in helping to prevent, risky things like going out and shaking everyone's hands and hugging everyone at the grocery store.
Again, we don't know the answer. We're actually hoping through P-Crowd and Promise to send surveys and ask the questions about COVID-19 and potentially even ask everyone who is on Promise and P-Crowd to help us answer this question. What is the risk of COVID-19 in an MGUS population? So you'll be seeing some of those events sent to many of you who are on the Promise and P-Crowd. But just to echo Craig, we know that there were vaccine studies, or when we vaccinate patients with MGUS and smoldering, they don't respond as well. They don't get that immune response to vaccines as a healthy individual. So that's already a sign that tells you the immune system, even at the MGUS stage, is not completely normal. And when we did some fancy single-cell RNA sequencing of the cells in the bone marrow, we actually found that it's true. Your immune cells at the MGUS stage don't look like the normal cell. They look like already changing as if they're going to myeloma. So you are at risk. The problem is, how much of risk are you at? Are you, to the extreme of myeloma? Probably not, but where are you in that risk category? The other thing is, myeloma as a diagnosis is rare compared to everything else, but MGUS is very common. We have 3% of the population over the age of 50 have MGUS, and that's what we know of. 2 to 3 times higher in African Americans. So that means many of us are walking around over the age of 50 with MGUS, and we don't even know that we have that risk factor. So I think it's important for us in this era of COVID-19 to actually think about screening in a much better way, to think about, is this an extra risk factor that I need to know about, other than age, other than having a different immune system, having asthma, although now asthma is not for sure a risk factor, having all of those other factors. Do I have a dysregulated immune system? Do I have MGUS? Do I have smoldering myeloma that potentially could put me at risk? And what is my risk? And that's why we need more research in that area. And hopefully we will be launching that soon.
Thank you both for answering that. I know that that's a really loaded question for a lot of our patients and something that's been on a lot of people's minds. As our Promise and P-Crowd participants know, we will be sending out surveys in the next couple of weeks that are hopefully going to help us answer those questions and put the precursor conditions a little bit more on the map in terms of understanding COVID risk. But I wanted to just in general get a broad sense. Dr. Winkfield, I know that you're a radiation oncologist and you do treat some other cancers, and I was wondering if you have seen COVID-19 put limitations on treatment across disease groups, and in general, how do you think physicians are prioritizing cancer treatment versus COVID-19 protection? It's almost a teeter-totter of issues to decide which is the worst of two evils.
Yeah, it's a very good question, and I can tell you patients are scared. Patients who are diagnosed with cancer are fearful, because they know that they have risk from the cancer, but they also know that they have increased risk related to COVID. And so, the oncologic community, and that includes medical oncology, surgical oncology, and radiation oncologists, have really been brainstorming about how can we really help to maintain the therapeutic ratio, meaning how can we ensure the safety of our patients, the safety of our staff, the safety of our nurses and physicians in the front line, and the safety of our patients and our family, but really balance that with the cancer risks. And so, we practice evidence-based medicine. That's what we do every day. And so many of the treatment regimens that we have, we recommend, have been studied through clinical trials and through research. And so we really rely on that. However, in this era, we are seeing some things change necessarily. If there's a way to delay care, we may. And people get nervous around that. But for instance, let me give you an example for men who have prostate cancer. If it's early stage, there may not be a rush to treat right now, particularly if they're getting radiation, which may be 9 weeks of therapy. Is that really reasonable to have somebody come in every day, Monday through Friday, for radiation therapy when they're putting themselves and their family at risk? Maybe not if there's a way to delay that care. Or starting men on androgen deprivation therapy, some type of hormonal therapy that can help to delay the treatment before they need to come in. Similarly, for women with breast cancer, if they have a breast tumor that is responsive to hormonal therapy, they may be put on a course of hormonal therapy if indeed they're nervous about coming in for radiation therapy. But I can tell you that's a conversation that oncologists around the country are having every day, not only amongst themselves, but also with their patients, because that's a discussion that needs to be had. And I do want to go back to this question about precursor lesions and why they're important. And again, I just want to highlight the importance of the PROMISE study. We know there are many cancers that are prevented through screening, one of which colorectal cancer, right? If someone has a polyp in their colon that's found during colonoscopy, and that polyp is removed, cancer has just been prevented. We know that polyps are a precursor lesion for colorectal cancer, okay? The challenge is that we know that MGUS and smoldering myeloma are precursor lesions, but what we're trying to do is understand the biology better so that we can then start to target early enough so that we can then prevent cancer. That's what the PROMISE study is all about. And the challenge, again, for when we talk about treatments across the board, African Americans tend to be involved in those clinical studies. Remember, I talked about those treatment studies that we use to create standard of care. Oftentimes, those clinical trials have fewer than 5% of individuals who are of African American descent enrolled. And so we've got to make sure that all communities of color, any of the racial and ethnic minority populations are included in clinical trials. And that's why there's such a huge push for this PROMISE study to make sure that we're getting out to the people who we know are not only are they at risk, but have a higher risk related to some of those social determinants of health of not being screened and tested early on for any cancer.
Thank you so much, Dr. Winkfield. And we love to promote the PROMISE study as much as we can because it is so important for our vulnerable populations, particularly during the pandemic right now when it's really coming to light the differences in disparities in access to healthcare. And I did this in the last webinar and I want to do it here as well. I just want to really thank the participants of PROMISE and P-Crowd who have signed up so far because it's really been able to push a lot of research forward that wouldn't be available if we didn't have you involved in our study. And one of the things that our active group of participants has asked about the COVID-19 pandemic is there a way for them to contribute to ongoing research while this is all going on? And one thing that I was hoping, Dr. Ghobrial, if you could clarify, is there seems to be a bit of confusion about how we test for COVID-19. So how would you define a positive result? And there's a lot of discussion about an IgG and IgM tests. How are those tests different than the IgG and the IgM levels that a patient receives at their regular appointments? Because I think that there's a little bit of confusion about those two things.
Question. So there are different methods to look for COVID-19. Some of them are PCR based, which is basically looking for the specific RNA of the virus itself. And these are from those nasal swabs or other methods. And some are looking for a response to the COVID-19, meaning they look at your blood and look for the antibodies, and the different antibodies are IgM, which is the first event that happens, and then later on, the more mature ones are the IgG, immunoglobulin G. So if we're looking at the immunoglobulins that respond to COVID-19 and measure those specific ones, not in general, the specific one to COVID-19, that's an IgM. And we say if you're IgM only, that you have a current infection. If you have both IgM and IgG, then maybe you're starting to recover. If you only have IgG, then you've recovered. So these are the methods that are being developed. Currently, there are so many different antibody tests that are being developed. Some of them are not approved yet. Some of them have limitations. So that's why there is a little bit of chaos in that area. But I think they will be here to stay with us to look for previously infected, and whether we have sustained response or sustained immune response to COVID-19 is an important question, especially in our immunocompromised people, especially in our myeloma and MGUS and smoldering. Do we sustain that immune response, or are we going to be susceptible again in the future?
Thank you. That's perfect. My last question right now, before we move on to a couple of other things in regards to the COVID-19 pandemic, is for both Dr. Cole and Dr. Ghobrial, have you changed or delayed treatment plans for precursor or myeloma patients, and what types of responses are you seeing to those treatment changes? I think this will be helpful for our patients to kind of get a sense of what to expect.
Craig.
Well, I think that one thing, the big thing that we've done is we've delayed people going to autologous stem cell transplantation. And so that we have stayed on track with collecting people for transplant. But the actual, we've had quite a few patients who were set to get transplants in April, in March, and in May, and we've delayed all those transplants and have continued them on their current therapy. And so I'll say that's probably one of the biggest changes I think we've made in treating patients with myeloma. And some of the new and some of the patients who are newly diagnosed with myeloma, and some people who have the recurrent myeloma, we've made some decisions of trying to limit them coming back and forth to the clinic and using more oral options. And so, there are options to treat newly diagnosed myeloma with intravenous drugs like carfilzomib, or using subcutaneous formulations like bortezomib. But we've gone to using all oral regimens, such using Ninlaro, the oral version of Velcade, and some of the induction therapies and some of the relapse therapies, and things that people have responded well to that. For some of the higher risk patients, higher risk myeloma and higher risk relapses, we've still stuck with using some of the IV therapies in order to get better control over their disease. I would say one of the biggest impacts has been actually in some of the precursor diseases. I used to see, all of my smoldering patients and all of my MGUS patients in person over and over and over again. And now I've loved using telemedicine to visit my patients. They get their labs at their local institutions a few days beforehand. And then we do a telemedicine visit for the MGUS patients and smoldering patients. And I get to see their dogs and cats and their homes. And visit them at being very convenient for them. And I think moving forward, after COVID's over, I would continue to see my MGUS and smoldering patients some of their visits over telemedicine.
I would totally echo that. I think there are lots of limitations currently. As we said, any intravenous infusion requires that the patients come to our clinic. And we've all switched and tried to figure out how can we still treat our patients with the best care, but limit their visits and limit them coming to the clinic. And I think we will learn a lot of lessons from this pandemic that hopefully will change practice for us all. We will learn to use more and more virtual medicine or telemedicine. As Craig said, many of us are actually and in fact, many of our patients are enjoying the virtual consults to the point that now we're thinking of making our own Center for Prevention of Progression, the CPOP clinic, going almost all virtual as much as we can, because we can reach all those patients with MGUS and smoldering at their homes. We don't have to make them fly all the way to Boston or even drive in Boston with the craziness. Although now the driving is perfect. No one is driving on the streets. But that idea of changing to virtual medicine, potentially even in the future, and I hope that happens in clinical trials and in many of the cares that we provide right now. We bring home care, that we've started bringing IV chemotherapy and IV care to the patients and using some of those novel ways of providing care, as well as changing some of our clinical trials and all the restrictions that we have in clinical trials, having them all have to come back for certain labs, having them to come back for certain visits. We need to adapt to the new change and potentially provide better care in the future when we learn from this, a pandemic, because there will be more, and we definitely want to learn and provide better care for our patients. Having said that, I agree that we're having limitations on how to provide the care for our patients. We closed many of the clinical trials. We've put many trials on hold. However, Promise and P-Crowd are virtual. You can go online and sign up anytime. And we're hoping that people sign up as much as you can. You're sitting there with your family, talk about it and sign up. And then when we're ready to open up again and send you the kits, you'll be one of those first participants in it. So there are trials that are available if they are virtual. And if you're on oral chemotherapy, you can still go on with your therapy.
Can I just add, one of the things that I think is really important, we're going to learn so much, right, through the information gathering that we're doing through this COVID era about what the best care is. And I think it's really a challenge to say, what are the outcomes if we are moving from an IV infusion regimen, to an oral? We don't know the answer to that yet, but we will gather that data and to see how people respond. The same thing from a radiation perspective. We are using shorter and shorter courses of therapy, and that's important. But I do think that this telehealth and telemedicine is likely going to be here to stay. But I wanted to issue a word of caution, particularly related to our underserved and vulnerable populations. We know that not everyone has access to telehealth. I'm finding it a struggle in the rural communities where people do not have broadband access. Lots of my families do not even have a computer in the home, or they have a phone that may not even have access to they don't have service. So it's really important to keep in mind as we're rolling this out and being proactive about ensuring that we are creating the infrastructure. Remember that built environment, those social determinants of health, that we're really thoughtful about that approach. Because as you know, multiple myeloma impacts African-American communities, and we know that many of them may not have access to internet or to smartphones and other ways that we've been engaging in telehealth with our patients. So it's really important just to keep that in mind, that as we are innovating and utilizing this learning experience through this crazy pandemic, that we actually are thoughtful of the vulnerable populations and making sure that everyone has access, and we're not deepening the gap that we already see.
Dr. Winkfield, that's a great point, and I think that's something that we are really trying to do with our P-Crowd and Promise studies, and we receive a lot of participant feedback all the time about novel strategies and creative avenues to tackle these types of issues. And I just want to say to those watching right now, if you have an idea of how to circumvent some of these problems in our society, and ways that our studies can be a benefit to your community, reach out to us. We have a huge staff team that's very excited to be creative and move progress forward. So that's a great point, and definitely something that needs to be reconsidered as we move out of this pandemic, which hopefully will happen very soon. So we have around 10 minutes left, and I do want to turn to some questions that have come in over the course of the webinar. That being said, we received a ton of questions, and we will be having regular webinars, so some of those are going to have to be saved for a later time. So I'm going to start with some of the ones that came through earlier or had a lot of people asking the same types of questions. And to begin with, Dr. Winkfield, I was hoping you could kind of touch a little bit on something that we've seen with COVID-19 is that obesity is a risk factor for poor outcomes. We also know that obesity impacts outcomes for multiple myeloma, as well as I'm sure does for other cancers. Why is this the case? And can you talk about that in the context of the African American community?
Sure. Yes, absolutely. And what is striking is that obesity is quickly becoming very close to the #1 modifiable risk factor for cancer, right? A lot of people know that smoking is a risk factor for cancer. They don't understand that obesity in and of itself is a risk factor for cancer. And the reason why this is really important for our Black and Brown communities is that obesity runs rampant. African Americans, Hispanic, American Indian populations really have some of the highest obesity rates in the nation. Like in some places, 50% of the population is obese. And so that's important to know. And it differs by state. I mean, I'm in a state now where we have about 30% of the population here is obese versus in Massachusetts where it was lower. So the obesity is really important. We're not 100% sure how it's impacting COVID, although there's some initial research that looks at changes in lipid profiles related to COVID. We know that in particular, COVID has a huge propensity to impact the lung parenchyma, the way that people are able to exchange oxygen through the lungs, and that we think that there may be some changes in the lipid layers. We're not 100% sure. Again, the science is coming, but we will understand better the interaction around that. But certainly being obese makes treatments more of a challenge. Right? It's more of a challenge to ensure better oxygenation. It's more of a challenge to get some of the treatments because they may not be able to give doses of medicines the way that they need to, or maybe the dose is ineffective because the body mass index is higher. So these are some of the considerations, but we are going to learn a lot, as we said before, in looking back, and as we're gathering the data around COVID, we'll know more about how directly related obesity is to the poor outcomes in COVID, but certainly we know that treatments in and of themselves can be a challenge when patients are obese, but it's something that we really have got to come to terms with in community in general, but particularly for our racial and ethnic minorities.
We with plasma cell disorders and specifically with myeloma, we know that especially obesity in late adult and early adulthood is related to myeloma incidence, and in that there's a cytokine, a chemical called adiponectin that goes down with obesity that actually causes cells to proliferate more and can increase the risk for cancers, including myeloma. And obesity causes the immune system, lots of changes with the immune system, in part to lower the immune system and to promote cytokines, and specifically one cytokine that myeloma just loves, interleukin-6, goes up with obesity and is again related to myeloma, as well as higher insulin levels and changes in sex hormones that go along with obesity that may cause disease progression and increase again the risk. And again, you can't change who you're related to. Can't change my brother and my sister. But the one risk that I can modify is obesity, because even though we'd like to do studies to see if modifying a weight would have would change progression and the incidence. And that's exactly why we're doing studies like the PROMISE study. And again, that's why it's critical to have people of ethnicity involved in these clinical trials to see what's the impact of things like obesity and progression of disease. And the interplay between the immune system, obesity, the cytokines, and genetics.
Thank you both. And I know that that's a tricky topic right now as we're all sitting at home with our pantries. But it is important thing to consider long term, and definitely something to speak with your physician about if you're concerned about your risk. I have two more questions that I want to ask before we close things up here. I just want to make sure I get them in. The first is a bit of a loaded question. We often talk about our MGUS and smoldering patients being either low or high risk. And there's a little bit potentially of an overlap for our high-risk MGUS patients and our low-risk smoldering patients. When a physician is talking about COVID-19 risk overall across this precursor spectrum, what are the types of serum immune cells and levels that a physician would consider? For example, some of our participants are asking about white blood cells, red blood cells, platelets, neutrophils, etc. How does that play into the COVID-19 picture?
Yeah, I mean, I can help a little bit with this, but I think I'll need Craig and Karen's help with this. So we know that there are risk factors for how fast or how likely you are to develop myeloma in your lifetime if you have MGUS or smoldering. And we base those on tumor burden, meaning how many cancer cells you have in your bone marrow. So if you have 30%, if you have 40%, 50%, you're starting to get at the higher level that will make you go into high risk smoldering myeloma and making you almost in myeloma stages. If your light chains are elevated and the ratio is elevated, that puts you at a risk. If your M spike, the monoclonal protein, is high, that puts you at risk. And then there are other factors that are immunoparesis, meaning if your IgG is the type that your cancer cells secrete, if your other immunoglobulins are low, that's also a risk. When we put all of those clinical factors together, it puts us into trying to figure out who's at risk for progression to myeloma. And there are so many models. There is one from Mayo Clinic, one from the Spanish group. There's a recent one called 20-20, meaning 20% cancer cells, 2 grams of protein in your blood, 20 light chain ratio. All of these factors are just telling us how many cancer cells are basically in your body, which gives you that risk of potentially progressing to myeloma. And as you heard from Craig, the more tumor cells you have, the more abnormal things are, the more your immune system is abnormal, and the more likelihood you have of not developing enough antibodies to COVID-19 or not responding well to it. But the true answer is we don't know. That's why we want to launch the new COVID-19 PCrowd PROMISE study, where we can ask you those questions. We get blood samples from you, and we actually do the research. We actually give you the true answer rather than a hypothesis answer of what is your risk for COVID-19.
Perfect. Thank you so much, Dr. Ghobrial. And our final question for the day is going to be looking forward to post-pandemic times. When our patients and our MGUS and smoldering and our myeloma patients return to their communities, and hopefully things return to as close to normal as they can be, there's conversations about the potential that this coronavirus would become something like a flu, something that happens annually. Are these patients, particularly someone who potentially had a bone marrow transplant in the past, are they at increased risks of exposure to this virus?
I think that we're really going to, rely on a lot of our public health and advice from the CDC on, how the virus is going to behave moving forward, especially, after the pandemic's over, when warmer weather comes and when, summer turns into fall. What is the virus going to do? And, will we have a vaccine available? I mean, one thing, we're going to learn a lot. There has never been a virus that has been more under the microscope in my career than this one. And there's going to be a lag time between when COVID is over and when it could potentially reemerge. That there's going to be a lot of research, including research with the PROMISE study about myeloma MGUS patients and precursor patients. But also, I listen to podcasts every day on all the research that's going on. So I think that we'll be well armed with science and research. When this comes back, we will be armed to the teeth with information of what to advise our patients with. And hopefully these will be lessons that we can learn from other pandemics that may come. We didn't quite see this coming, but after you fool me once, shame on you, but fool me twice. You're not going to fool me twice with this disease. That we're going to be really ready and be able to advise our patients excellently, if that's a word, moving forward.
So one of the things that I think is really important is, yes, while we're gathering data, it may be a while before we have all the answers, but let me tell you what's really important right now for all of our patients. Doesn't matter whether you have MGUS or smoldering or multiple myeloma or another type of cancer. Do your part, protect yourself. And we tell all of our patients who are going through chemotherapy anyway, reduce your risk by, if you know somebody's sick, kind of restricting. Right now, because we know that this country is under testing for COVID, we're under testing, right? So we don't know who's at risk right now. We don't know who has COVID, who's kind of cleared it. So it's really important to protect yourself. Wash your hands. Make sure you wash your hands. I've been struggling. You've seen me. I've probably touched my face twice during this webinar, right? I'm struggling, right? So wash your hands. Make sure that you're wearing your masks outside, and really keep making sure that you are physically distancing, not social distancing. We don't want you to be hermits. Get on the Skype if you can, get on the telephone and call folks, be engaged with your community, protect your mental health, but also protect your physical health by making sure that you are staying safe and protecting yourselves and your family.
All right, thank you so much, everyone, again, for joining us on the webinar today. That was all we had time for this afternoon, but we will have another webinar upcoming in actually less than 3 weeks. So stay tuned for that. To learn more about the PROMISE study, you can visit our website, which is www.promisestudy.org. We've been talking about it all evening, but there's plenty of time to do this while you're sitting at home. So if you're struggling and have difficulties, please reach out. Our team is very active and happy to help you with any problems you might encounter. Thank you to everyone who submitted questions. We are going to compile those and look at the ones that we weren't able to answer and hopefully include those in our next webinar. But for the time being, I just really want to thank Dr. Ghobrial, Dr. Winkfield, and Dr. Cole for joining me today. I think that this was a huge success and our patients do really appreciate it, as does our entire community. So thank you all.
Thank you.
Thank you.
Thank you, Annie, and thanks for the whole team who did all of this.
Everyone stay safe, and we will all see you soon.
Take care.
Take care.
Bye.
Bye.